الرحيم.
السلام عليكم.
وعليكم السلام. Okay, good.
الخير.
I think we're complete and we can start our webinar. السلام عليكم ورحمة الله وبركاته وكل عام وانتم بخير. Welcome to the first regional spine webinar in the collaboration between the Saudi Spine Society and the Egyptian Spine Association. It is my honor to present to you an elite faculty from both Saudi Arabia and Egypt. We have today Dr. Abdul Wahid Barnawi. He's a neurospine surgeon in Prince Sultan Military Medical Complex in Riyadh. We have Dr. Basim Awad from Mansoura University in Egypt. We have Dr. Mohammed Khashab, Assistant Professor at King Saud bin Abdul Aziz University for Health Sciences, National Guard in Jeddah. We have Dr. Bilal Al-Nadi also he's an Assistant Professor from Asyut University. We also have Dr. Amr Al-Habib. He's a neurospine surgeon from King Saud University in Riyadh. And last but not least, we have Dr. Mohammed Fawzi Khattab, Associate Professor at Ain Shams University. Welcome, everybody, and it's an honor to be here.
أهلا أخونا العزيز. بسم الله الرحمن الرحيم.
بسم الله الرحمن الرحيم. So we'll start our first talk with Dr. Abdul Wahid Barnawi, and he's going to be talking about revision surgery in spinal lesions. The mic is yours, Dr. Barnawi.
All right. الله يديك العافية. شكرا جزيلا دكتور هاني. You can see I share my screen. Is that right?
Yes, we can see that.
Yes, you are sharing your screen.
Okay. رمضان مبارك للكل. I'm happy really to start the session and just to thank Triple S as well as the Egyptian Spine Society for this initiative and this opportunity during this difficult time. Although they are still building, all the people actually are keeping, and all the world keeping the distance and separation between each other. And we still, between Egyptian Spine Society and Triple S, we are still connecting with each other. Today, I hope me and my other speaker, we can give the goal of this speech, inshallah. We are talking our main things today about surgical revision, and if I would like to define surgical revision, it will be the repeated operation for the same condition in the same patient due to disease progression or recurrence, or as a follow-up to failed previous surgery. I said that I'm going to present for you a case for one of young patient. He's an aircraft, studying aircraft engineering. He came to me in 2017. Let me just put the timer so I will not forget my time. He started to feel progressive weakness of his both lower limb, and he became unable to walk with a sphincter disturbance. And he sought medical advice in several hospitals. They scan him and also they biopsy him. And according to the result, they refer him to our spine surgeons. When he came, his examination showed severe weakness. He's only flickering in one of his leg with most of his muscle group is 0/5, and he has sensory level, and he wasn't fully catheter. He is complaining of back tenderness. This is his CT scan. Clearly for you, show destructive lesion. This is his T4, by the way. This is T4, and this is T4, and this is T3. So it's reaching T4, T3, T5. Most of the T3 is T4. I mean, is being eaten up, taking even the left side of the pedicles as well as part of the body. MRI was more obvious here. You can see the classical picture of TP spine. There is some epidural collection with destructive lesion as well. You can see even paravertebral collection as well. You can see here the T4 is almost gone. And also the disc at this stage is being involved. That indicate that is really in a late stage. Based on this investigation, and after we did for him all the lab workup again, and we are sure that we are dealing with the TB, we went and we did for him posterior decompression. We evacuate most of the collection around the epidural space, as well as we went transpedural approach to reach the anterior part of the for anterior part to the dura. Patient, he did very well. This is the post-op CT scan. It was satisfactory. And I went to T1 and T2. T3, we didn't put anything. T4 and T5, nothing. And then 6 and 7 and 8. Patient started anti-TB by ID team after that and start on rehabilitation program. He showed great improvement. Both his lower limb is become back to 5/5 in all muscle group, and he's able even to catch his next semester to go back to his college. And this is just a routine follow-up MRI he did for him. It showed that there is a significant improvement in the epidural collection, but I can see still some anterior to the spine. There is some collection there. So that is really make me think what happening. By this time, that was almost 6 months from the surgery, and still have collection. Usually, you can see really significant improvement. You cannot see even some the oxidate as well. So we kept him actually in close follow-up, maybe like every 2 to 3 months, and he have like open gate anytime he would like to pass to my clinic to come, just because I would like to be sure that he will not have something because of this anterior collection. And what it happened, in fact, in one of his visits in 2019, he came complaining of heart numbness. And when we examine him, we find that he have 3 to 4 out of 5 the right hand grip. So immediately we did for him an MRI. And this is the MRI. This is the MRI result. You can see here in the sagittal view, there is some things here extending, in fact, from maybe T6 down to T1 or something. And I can see it here more. It is an epidural collection more and compressing the cord to this side, to the left side. So that was alarming, and we cannot ignore. So this is an axial cut. You can see is going all the way through the foramen, and this is, I think, the level of T7. I mean C7. So what you will do, if I can ask one of my colleague, Dr. Bilal, what you will do in such cases?
Actually, can you put the last X-ray again?
Sure. Yeah, no. Yeah, this is the last X-ray. This is the last X-ray. This is the last MRI we did for him. There is some collection, and you can, maybe it's not clear so much in your screen, but there is some collection here, epidural, going to the foramen and pushing the cord in C7 mainly to the left side. So I was really not sure. So shall I go really aggressive with this patient, and why he having the TB spine? Why he TB spine most of the time when they
problem in this video?
Sorry.
Is there a problem in dorsal?
Can you say it again, Dr. Bilal?
This dorsal 3, the dorsal 3 vertebra, is there is
Yeah.
any problem, collapse or something like that?
Dorsal 3, it seemed that it's stable, but in the other images, there is some, I can show you in the other one, is more clear. Maybe you can see it here. In the previous one, this one is more clear here. But when we go in this one, the main thing is opposite to C7 and T1, and
actually, I will go for posterior decompression, and I will prepare instrumentation if needed.
If needed, yeah, okay. In fact, that's what we did, and it was my question why he developed, why he having this one. Even we asked him, you are in the treatment, you complete your treatment already, you are in close follow-up with the ID team, and all your marker was really good, is going down. Almost he become like normalized ESR, CRB, everything is good. And now we have the things. So we said we will go. Most likely we are dealing with the TB again, and we choose to go, as you mentioned, Dr. Bilal. We go for posterior decompression, but I didn't use at that time. I limit myself to the very limited laminectomy and able to drain all this collection. Patient, he did very well. His grip movement improved, no more numbness. But 2 months ago, he came with the cervical pain. He came with the cervical.
1 minute, Dr. Barnawi.
Yeah.
You have 1 minute for your presentation.
Okay, sorry?
You have 1 minute remaining.
1 minute remaining, okay. So we have this cervical pain with limited, also his left hand with left hand weakness, and this is his MRI. The MRI was showing really aggressive at this time, involving the T7, also C7, I mean, with also collection anterior and posterior, and I will not discuss it with you at this moment because of the time, but we went for anterior at this moment, and patient, he did really great. This is a post-op MRI. I was just saying that the drug resistance, why the people, they develop drug resistance. And most of the time because of their compliance, or sometimes it can go to the genetic cause as well. And when we can say this patient, he developed drug resistance, when he's on anti-TB treatment for 5 months and is still showing poor clinical or radiological response, or he have deterioration in spinal deformity or discharging sinus or wound dehiscence. At that time, you can say that patient he have drug resistance TB. This is guys, I share, maybe Bilal, he shared with you some polls, some question. I hope you have the answer by now. The answer is, for example, for this question, I put the main factor contributing to the development of drug resistance in TB. What is it? It is inadequate, or 1 or 2, 3, 4, 5, and this is the answer. It will be, yeah, the number 5, all of the above. And I conclude my speech with the last question. I put it for you. I think you refute, all of you, and the answer here is number 1. Thank you very much.
Thank you very much, Dr. Barnawi. I think we have just a couple of questions from the audience. The first one is the Professor Kumbaz was asking, was the patient compliant on TB medications, and how do you make sure that these patients are compliant when it comes to long-term TB?
That's our first question, actually. We asked him, are you compliant? He swear God that he's compliant. And he's very much educated, and he was in close follow-up with with the ID team. So there is, we cannot say anything regarding his compliance because he swear God and we believe him. Yeah.
So maybe he's unlucky. So I think most of the tertiary centers who deal with these types of cases of infection, I mean, we have the cooperation of the ID team, and in most centers, I think they follow up patients closely. Nowadays, we have more people who are specialized and involved in these situations. But the other question from Dr. Kumbaz also was the patient tested for any immunodeficiency like
Yes.
HIV or
Exactly, yeah.
autoimmune?
Immediately when we saw him next time, actually we screened him with the HIV and all that stuff, and all it came negative. All it came negative. Because that's one of the reasons you need to suspect if your patient have, if he developed drug resistance, this is one of the things you need to do actually, just to see if he's immunocompromised for anything. Maybe the last slide, it show one of the study is being actually published here in Saudi Arabia, where is it's done by infectious disease doctors, where they did actually, and they found that most of patients they develop the a multi-drug resistance TB is due to either they have immunocompromise, like renal patient have diabetes mellitus, and surprisingly they find it actually in female more than male as well, and they find it more in young patient more than older people as well.
Last question I would ask you, Dr. Barnawi. There was a question here. Did the culture show any resistance? I mean, did you have any interoperative specimens which showed resistance?
Exactly. In the second one, when we send it, it showed really significant resistance for both for the rifampicin as well as the isoniazid for both. So it is multi-drug resistance, and we know that if it is only for one treatment, we say mono, but it is or rifampicin resistance, but this one is multi-drug resistance. Thanks God he is not extensive type.
Well, alhamdulillah, maybe he was unlucky, but now he's lucky, alhamdulillah. I think we should move on for the sake of time. So I leave the floor for Prof. Muhammad Khattab to present the next speaker, if you don't mind.
Thank you, Dr. Abdel Wahid. Very nice case. And the next speaker will be Dr. Basim Awad, Associate Professor of Neurosurgery in Mansoura University. He will discuss cervical reconstruction as well. Please, Dr. Basim, go ahead.
Can you hear me good right
yes,
now?
Yes, you are unmuted now. Okay, please go ahead.
So it's my honor and pleasure to present and share one of my cases. I started doing this early on in my career, actually. So this patient was presented, he's 32 years old male, presented to us with severe neck pain, quadriparesis, and he's a drug IV addict person. So he presented with these images like this. He have a very significant infection. It involved actually C6, 7, and D1 with an abscess here, an epidural abscess. And you can see here in the other images at T1 how bad this infection is, and involved with C4 as well. So if you look to the CT scan, there is an extensive distraction of C7, 6 as well, and D1. So the plan was to go anteriorly and decompress, clear the infection, do corpectomy to the C levels, and fuse this patient from the front. And actually, we have many questions in our mind at that time. So are we going to do a reconstruction from the front using a graft, autograft, or putting a bioremission plate? Are you going to put a bone substitute or not? Do we need to do a posterior augmentation for this case or not? So actually we went to this case from the front, and we did a corpectomy for the 3 levels and put a pyramesh, bone graft, and actually what a plate. And we discussed with the patient that after surgery, we will need another surgery to do a posterior augmentation. So after we finished the first case and first surgery, the patient was very happy that the pain improved dramatically, and he started neurological improvement as well. So he is an unreliable person, and he is a drug addict. And actually, we offer him that next week we are going to do a posterior augmentation and fixation. So actually, the patient refused doing this, and then he quit from the hospital. And this is one of the mistakes we did, I believe, that if you have a non-reliable patient, you have to finish the whole job in one time. And don't rely that this patient will be cooperative to you and he will listen, and then he will give you the chance to do what you want to do. So actually, he quit from the hospital, and then um, he presented to us like 2 months after he started having a severe neck pain. He is holding his head like this, and he started having weakness again. And then we did a scanning, and this is what we found. Actually, we have a failed construct, and the graft is getting out, and the plate as well. So what's the problem with this? We believe that we have the main issue that if you have 2-level corpectomy or more, you need to augment this from the back. And as I said before, if you have an unreliable patient like this, so it's better to finish the whole job at the first surgery. So I believe that it was better for us when we finished the front surgery to do it from the back and augment what we did posterior, but we didn't. So he present with this. So so we plan to go again and correct this and removing the old system, doing corpectomy for the destruct vertebrae at the above construct, doing another graft plate, and both doing posterior at the same time. But actually, you can't believe when you approach a patient that have heavy infection like this, and actually this is recurrence, and we did surgery on him before. So you can imagine how bad and terrible your approach and doing this surgery again. So we opened the patient, and we found again a very heavy infection. And again, the second mistake that I did, and I present this here that because I'd like to let most of you know that I put artificial or synthetic bone graft in the biomesh, and this is completely wrong. So if you have a heavy infection like this, you have to put an autograft. This is the best way to treat infection. So iliac bone crest or whatever natural bone is the best for infection. So what I did an artificial synthetic bone in the graft, and this is wrong, as I said, and I found a heavy infection. So second point I did, which allow the graft to subside from the infection that we got at the site of the first surgery. So I said, okay, I have to clean this. I have to put a natural bone. So what I actually did, I said, okay, I'll take a fibula. Okay. So we said, okay, we'll take a fibula and put an oversized fibula and try to put this inside and clean the infection and flip the patient and do posterior augmentation. So we did this, and then we did the posterior augmentation, putting graft and everything. And actually, the third mistake that we did, that we didn't put any anterior support to the fibula. Okay, the fibula actually is very hard bone graft, and we said, okay, I'm not going to put a plate again or any metal. So I was a little bit an idiot guy, the first of my career, and said, okay, I'll just put this fibula, and then I'll do posterior fixation. That's it. And actually, after 2 weeks, what was expecting that this patient having a fibula getting out from the graft again. So this is the third mistake that I did in this case, that I bought the fibula and said there is a heavy infection, so I'm not going to put any met on the front. And I just put the fibula oversized and do a posterior and going down to the thoracic spine and going above in the cervical spine. And this is again a very like beginner mistake. Never ever do putting any graft without any anterior support like we did. So again, we take the patient and then we shorten the graft, put it again, putting a plate, and actually I didn't see the patient again, and thanks God, he I think probably he's doing okay because he didn't show up after this horrible surgery. And people usually say the patient can trust you for the first time, and sometimes they can trust you for the second time to correct what you did, but he will never ever trust you for the third time, because now probably you are an idiot because you can't correct yourself for 3 times in a row. So that's actually what we did, and we did him the 3 surgeries, and he didn't show up. So probably he's doing okay after this what we did for him, and that's what I have for this case presentation.
Thank you very much, Basim. A very nice case, but actually I'd like to tell you something. God bless you. You are operating upon HIV positive patient for 3 times, and I am sure it is for free surgery. So you are really a hero. No one can do this. I'd like to ask you a question, Basim. You revised him anteriorly twice, 3 times. The first approach was right-sided approach, the second one left-sided approach, the third one, or all from one approach, one incision, right or left?
All of them from the same incision.
All of them from the same incision. Yeah. And due to the infection, you don't have, due to the infection, you have a tissue plane to go again inside, or there is a lot of adhesions. What is the tips and tricks in doing revision surgery from anterior?
Man, it was horrible surgery. I'm telling you, there's a huge infection. There's huge adhesions. Everything was crazy, and I was very worried about doing any esophageal injuries or anything like this. But there was some kind of plane from the bus that guide you to the metal where you're putting your graft in. But I go from the same side, and it was terribly bad. Adhesions and everything.
Okay, Basim, thank you for highlighting one important issue. TB, tuberculosis, is completely different from pyogenic infection. In pyogenic infection, I do believe it is very important to do anterior and posterior augmentation in your construct. For example, unlike what we saw with the Abdelwahid case, he relied on only one side tactic to approach the tuberculosis. Tuberculosis is a little bit forgiving, but in infection, I do believe to do anterior and posterior, the full program is very important. Now we have some questions from the attendees. One of the colleagues asking about the titanium cage. Do you consider it a contraindication in infection and you rely on graft better, or do you think it is okay with titanium as well?
Yeah, I think it's okay if you put a titanium cage, but it's important to put an autograft inside the cage, not putting a synthetic bone graft.
Yes, okay. So titanium is okay, bone graft is okay, but no artificial bone graft. It is actually a dead bone. It is a foreign body. It can invite more infection. Completely agree. Of course, you are doing fusion, so the patient will have limited motion in his neck. But the challenge was dealing with HIV patient. What is your precautions? How you managed this? We want to hear from you how to deal with HIV positive cases.
So actually, we did an HIV for this patient, and it was negative.
Negative, although you stated it was HIV.
No, I did. He wasn't an HIV case. Yeah, he was a drug addict. He's IV drug addict.
Okay.
He wasn't an HIV, so he was negative. But we have an HIV case at once. He was a physician actually, and he has like unbelievable, horrible infection in his back, lumbosacral. And actually, we were very afraid to touching this guy. And the hospital administration was very strict in this issue, and they said we have to operate on this patient. So one of my colleagues, he was a hero, and he did operate on this guy. So, but I didn't in my life. Yeah, to operate on a guy, I know he's an HIV.
Basim, do you have navigation in your department?
We don't have a navigation, but we have now an intraoperative ultrasound. So we use this. It's very helpful, especially in spinal tumors and intramedullary lesions and stuff like this. But it's not helpful in instrumentations.
Okay. Dr. Basim, why would you on an HIV patient?
I'm sorry?
Operate on HIV patient?
Why I don't?
Yeah, you don't want to.
No, I'm just saying I never did this in my life.
Okay, I see.
Yeah, I didn't did a patient that I know he's in HIV.
Because, you know, with the precautions, sometimes we have to do some things, you know, even if we don't want. But if we follow the precaution and all that stuff, I think it will be all right.
Yeah, exactly. Yeah, I agree. You have to help the patient, even you know that he's in HIV. But I didn't.
If I may, I have a quick question, Dr.
Sure.
Basim.
Please.
Really brave, really challenging case. يعني
Thanks. Yeah.
صراحة جزاك الله خيرا يعني. Most people will just يعني bail on these patients. My question is يعني going 3 times from the front and access. Do you? I mean, will you ask the help of any colleague from, for example, head and neck surgery to help you in these cases, especially these complex cases with adhesions? Maybe it will make your life easier, I think.
Yeah, it's a very good point, actually. By the second time, and I have one of my colleagues, but he's a spine surgeon as well. He joined me during this case, and he helped me getting the fibula and preparing the stuff for me. But actually, I didn't get the help from an ENT guy. But I think next time, if I have something like this, I'll consider doing this and take help from those people like that. But
yeah,
hopefully, I'm not in this situation again.
You will never have enough help in these cases.
Yeah.
The more help, the better.
So the final question I'd like to ask the whole panel: is any one of you dealt before with HIV positive patient, and what is the precautions? Because this is typed 2 times from the attendees how to manage patient with HIV positive and when they are needing surgery. Is any one of you have experience with that? Personally, I didn't operate HIV patient before. Maybe, and of course, maybe it is very important to have special gloves. It is very important to have face shield. It is very important to tell the whole team that our patient is HIV positive, from the anesthesia to the nurses, the workers. It is very important to sterilize the instruments many times afterward. Use disposable drapes, use disposable things, instruments, whatever, as much as you can. Something else to be added, brothers?
You say it, Dr. Muhammad. I dealt with one patient.
Yes,
He had epidural hematoma, and he was an HIV positive. What we did is just, as you mentioned, the whole precaution, more than double gloves you take, and just be sure that in addition to what you said, maybe try to minimize the drilling and all that stuff. Although you are wearing already the goggly, the eye goggle and all that stuff, but in the same time, try to minimize using anything can spread the fluid. Like irrigation, have to be very much careful with your irrigation, as well as your drilling. You have to be more careful with your drilling as well. That's it. Otherwise, the same.
Thank you, Dr. Abdul Wahid. So back to our dear friend, co-moderator, Dr. Hani Sulaimani, for the next speaker. Thank you very much.
Thank you, Dr. Khattab. So our next speaker will be Dr. Mohammed Khashab, and he will be talking about adjacent segment after 2-level ACDF and cervical spine.
Thank you, Dr. Soleimani, for the introduction, and thank you all. Great cases, doctors, so far, and what a complex infections that we've been through. But I'm going to shift the gear a bit toward different pathology. So we will take you through another pathology, which is the degenerative spine. It's a common problem. I think we got to see in our daily practice more frequently compared to the other pathology. So I'm going to take you all through a case that I've seen is not as complex as we may expect with multiple revisions, but this is only a case that presented to me complaining of a neck pain. He's a 75-year-old gentleman who had a neck pain that's been there for a couple of years with an arm pain, tingling sensation, and some radicular manifestation in his hand that was addressed in another institutes in another country about 6 months earlier prior to the presentation. And in addition to that, he has a good history of comorbid disease, hypertension, diabetes, ischemic heart disease, but all were maintained on management. So when I saw him and examined him, he was good for his age, I mean, physically, and he's active. He has a localized tenderness at his cervical spine, mainly mid-cervical spine, paraspinal. And he has a positive Sperling test on the right side. And neurologically was not showing a significant deficits. But he has a significant brachyalgia. He has an arm pain that is really interfering with his daily routine and even sleep. He sometimes take a nap on a chair in order to maintain a certain position to relieve the pain. So this is plain X-ray. As you see, he has double level standalone cages that is still on the healing stage. And when you do dynamic flexion and extension, you could see some occult instability at the C4-5 level, adjacent level. And the CT showing the ongoing fusion process at the disc level. And you can see globally kyphotic cervical spine and some degeneration on the MRI as well, but there's no specific compression on nerve roots, and that can also go with the clinical finding. So we got you this MCQ for the whole audience. If they would like to answer this, what exactly you want to do at this stage, whether you would go conservative and no touch, since he has just an axial neck pain and some radicular manifestation, or you would like just to go on with the adjacent level, hoping to improve that by putting what we call cervical disc replacement, hoping to solve this problem. And keeping that motion is becoming more exciting over the past years. Or you want to go and revise the levels in addition to additional level from C4 to C7 and correct the kyphosis all from the front without anything else. Or you would like to do both anterior and posterior, similar to the infection case that we have been presented. So you could do the voting. By the time I'm going to take you through some slides to possibly help in the clarifying this pathology. So I'm going to change a bit the configuration of this talks. So a few slides on the topic itself, spondylosis. We know that it's very common, and commonly in elderly, and it causes radiculopathy or myelopathy or even axial neck pain. And we got the standard of care. It's becoming a standard of care over the past 50 years, the ACDF, but it's been blamed for what we call it adjacent segment disease. Is it true? We don't know. Is it what we do cause the degenerative changes, or it's actually a natural history of the aging process? To answer this question, we look at few studies. This Hellbrand reported in the late 90s. His data
that showed a 10 years follow-up, and he reported about 3% incidence per year of a degenerative changes of the adjacent level at the ACDF. Another radiological studies looked at the cases with the cervical fusion and found that a follow-up of 8 years showed 90% of degenerative changes. So based on these, yes, it does probably cause, but they noticed something interesting, that those patients who is younger age, where they had trauma, for instance, and did not show a degenerative adjacent level disease compared to the elderly. So focusing on the elderly with the degenerative changes might be the cause behind that. So another studies looked at those cases with a non-fusion, like foraminotomy, looked at the two groups. If you look at the higher one, it looked at the patient with a foraminotomy and a follow-up of 4 years and showed up to 50% degenerative changes at the adjacent level while they just did the foraminotomy, compared with the ACDF, which got even lower incidence with the 40%. The other study looked at the same finding at a 7 years follow-up, and they showed only 5% and only less than 1% required surgical management. Now, many of us would think, and it's been exciting over the past 10 to 20 years, the disc replacement. At the adjacent level, it will help in reducing the stress and could be the best option to be picked up in the case we presented. So we looked at this data, systematic review, looked at all of these 15 articles in 2015, and concluded that actually you do see a reduced 50% chance of adjacent level disease. But again, you need to look at who is the proper patient to be selected for this. So putting a disc replacement might be just an expensive way to achieve a fusion, and actually can be more of a problem rather than just a segment disease. So another study looked at the anterior cervical disc replacement versus an ACDF, looked about 4,000 patients included in this study, and the conclusion that the disc replacement group has significantly better neurological outcome as well as lower rate of adjacent segment disease. And when they looked at the parameters, the remaining parameters, which is operative time, blood loss, long-term complication rate, and reoperation rate, were all the same. So what to do in order to improve or reduce the chance of the adjacent segment disease right from the beginning? So thinking of planning, this study looked at specifically, I'm going to let you look at the disc height specifically in this paper. They found that the disc height is an important predictor. So if you get a patient with a disc height that is over distracted, that's going to improve, that's going to actually increase the chance of adjacent segment disease. So putting the proper size of the cage, restoring the disc height is the ideal, but not over distracting. Otherwise, you're going to end up with causing adjacent segment disease higher. Another paper looked at the other parameters of the same condition, whether you could predict things that would improve the outcome by looking at the plate to disc space. So whenever you have an end of your plate to the disc height less than a 5 millimeter, and you're including more than multiple level fusion, then that's going to be a risk for adjacent segment disease. So in conclusion, we need to be sure that we don't have really a clear data supporting that possible incidence of adjacent segment disease due to the ACDF. The risk factor, disc height, plate to disc distance, and multiple level fusion, all will put the patient at risk for developing this. So in conclusion, taking you back to the case that we've put at the beginning, I elected to do a fusion from the front, and I was on the point of in between, doing everything from the front plus or minus the back. So I was comfortable when I did the front that this might be enough. So I observed this patient closely for a possibility of going to the back, and I found him stable and satisfied with the outcome. So he's now a year out, and so far he's still okay. Can we see the results of the voting?
Can you put the results for the
Mr. Bilal, our host, kindly, yes, show the results. So 46% of the attendees are more with the posterior lateral mass from C4 to C7, and only 23% with your decision. So many ways
Well,
to
Prof,
go.
Prof, let me ask you this question. Based on the clinical presentation, can you help me with this? Do you think leaving patient, I was surprised that 25% of the audience think that you're supposed not to go for surgical management in spite of the way the spine looked like on the x-ray and the presentation. Would you
Yes.
consider that, Prof?
No, no, absolutely no. The patient has a significant complaint. His quality of life is affected. He has kyphosis. It is not fused as well. I do believe so. Inflection, extension, these two levels are not that properly fused. So I am really with surgical intervention. I
Just
cannot
only
accept conservative management. Maybe
Sorry?
you show. Can you show them the X-rays again, Muhammad?
Sure. You mean dynamics?
Yes.
Yeah. So if you look at this dynamic views, you could see that the adjacent level is collapsing at the
Yes.
higher up, and there's the lithosis you could see clearly between flexion and extension.
So can I have a question, please?
Go ahead.
Yes, Basim.
Yeah, so I attend a fellowship with Dan Rue. He's a great cervical spine surgeon, and he have a very good trick to look at pseudoarthrosis in the cervical spine. Okay, so he's doing a dynamic flexion and extension X-rays for the patient, and he looking to the distance between the spinous process for each segment he did a fusion in. So if you look to the dynamic, like for the lower level, and you look to the extension, and you look the distance between the spinous process, and look how gapping with the flexion view. So you can see there is a big motion here at this level. That means this level is not fused yet. So he measured this, and he looked if this is over 1
millimeter.
1 millimeter. And actually, he's doing this in his office, and he is doing all these measures. And actually, it's very dramatic way to find this out. So this is clear by your eye, even, and you can look how gapping between the lower level, the spinous process with the dynamic flexion and extension. That means probably this level is pseudoarthrosis and it's not fused yet. So what I'm thinking is, if you keep this and you just put a plate, is it going to fuse after this time, or do you need to re-prepare the end plate and putting another graft, or you have to do corpectomy on this level? Just thinking about this, because it looks like it's not fused yet.
Yeah, good point. I think he was still not showing a solid fusion, as you could see between the dynamics. You could still that level is still collapsing, and you can see it changed the alignment. So you can see the difference between the extension and flexion, and simply by just distracting it and applying a cage adjacent level and realigning things with the contouring plate, we're able to get you the proper alignment. And he was okay till a year follow-up. I think revising it, taking the cage off, I don't think I will be able to put another cage. I think taking those cages off would mean corpectomy to me. I think that body in between will
I
be
totally agree with you. Yeah, it will be optimum to do a corpectomy at this level, and putting another graft, and then extend an ACDF at the level above, and then putting your plate in. One another trick I'd like to share with you is if you have a solid fusion at the level that you fused earlier, you can see the facet joint is filled with bone. So if you see the facet joint filled with space and still there is a fluid in the joint or something like that, that means this level is not fused. But if you see the facet joint and in between the facet there is a bone, that means this is solidly fused. This is one of the tricks I learned from him.
Great. Good point.
I agree with Bassem. Yeah, that's a good point. But I think in this case it was a little bit early, Dr. Khashab.
He presented within 6 months' time from the time of initial surgery.
So usually fusion rates may be delayed 1 to 2 years in some cases, depending on also the comorbidities and if the patient is a smoker or not, and also multiple levels also increase the incidence of pseudoarthrosis. We have just one more question here. Why don't you go and fuse posteriorly C4-5, Dr. Khashab?
That was my second stage. I was observing having his comorbid disease. So, and I was satisfied with his bony fixation from the front. So I kept him through the first stage. He was knowing that he might be going for the posterior stage. If we see any changes in the follow-up X-ray or developing symptoms, but we observed him and he was doing well. So I elected not to do it. So it was just a possible second stage if it's needed. And so far, I think it went well. I think up to 1 year, he's fine. I think it would probably was a good decision not to operate directly, just for addressing things that might not be needed.
Okay, great case, Dr. Khashab. I think for the sake of time, we need to move forward. I'll just remind the speakers, please, if you have any poll questions, just announce that before you proceed to the next slide, so we'll have time to put on the poll questions. So now I'll leave the floor for Dr. Khattab again to present the next speaker.
Thank you, Dr. Hani. Very nice presentation, Dr. Khashab. And from cervical pseudoarthrosis and adjacent segment disease to the lumbar pseudoarthrosis, our dear friend, Professor Dr. Bilal Nadi from Asyut University will present lumbar pseudoarthrosis and his technique in managing these cases by furrow technique. Dr. Bilal, kindly start your presentation and share your screen.
Thank you very much, my dear friend, Dr. Mohammed Fawzi. And thank you, my dear colleagues, for giving me the chance to be with this nice faculties. Actually, I have a message from this presentation, and I titled it, the use of accessory rods and spinopelvic fixation for lumbosacral pseudoarthrosis revision. As all of us know, the rate of spinal fusion surgery is increasing, and with this, the reoperation rate and the revisions are also increasing. And this revision surgery is usually challenging for both the surgeons and stressful for the patients. And usually a considerable percentage of these revisions is due to improper primary management, as we will see from my presentation. And actually, when you revise a lumbar pseudoarthrosis, you have a common problems. And most of these problems include the osteoporosis, because usually we are dealing with a revision degenerative disease in elderly patient after long period of hospitalization or limited mobility, and this responsible for many osteoporosis. And usually you have a poor screw purchases, especially if you have a previous screws, and then you have to put a thicker screws, and the screw purchase usually is not that much that you can depend on. And usually you need to use more healthy vertebra to add an anchor points to protect your revision. And actually, recently, there is a multiple publications about the use of supplemental and accessory rods with different techniques, either 3-rod technique or 4-rod techniques. And actually, the recent literature is full of data about these accessory rods. And most of these literature have proved that the accessory rods significantly reduce the rod strain and the incidence of rod fracture. And those rods increase the stability of the construct with lower incidence of non-union and, of course, less reoperation rate. However, Most of this data was studying the use of accessory rod in adult spine deformity or pedicle subtraction or osteotomy of the lumbar spine, I mean in spinal deformity correction. However, and the idea come to me, if these accessory rods are working very fine in deformity cases, we can use it also in complex revision surgeries after lumbar pseudoarthrosis. And I will show rapidly some of these cases to have the message of this lecture. For example, if we have this patient, this is a 55 years old patient. He had a previous L4-5 spondylodiscitis and he underwent somewhere posterior fixation, debridement with insufficient result. And the patient has some wound troubles after surgery. And then a second surgery was done, removing the metal, debridement, and the patient was left with this MRI at the right side. And so if we looked at this MRI, we have a clear pseudoarthrosis, still infection inside the disc. And if we looked at this L5 vertebrae, the upper part is mostly destroyed. And usually if I'm planning for another revision surgery, I may suggest that this L5 vertebra will not hold good screws. So I have to, actually I'm a posterior surgeon, so the possibility of anterior debridement is not in my mind always, but I mean from the posterior point of view. So the upper part of this vertebra is usually destroyed. It will not hold the screws anymore. So I will depend on S1 fixation, and I will put L3, L4 fixation. And this, after debridement, I may need partial or complete corpectomy with long mesh cage. So for me, to depend only on S1, 2 screws at S1 fixation in a 55 years patient after third revision is not a good option for me. So my plan was to do this: go posterior, debridement, partial corpectomy, and the use of these accessory rod techniques. And I put accessory rod, iliac fixation to more stabilization, and I believe that this construct was a little bit stable, and it can protect this long mesh cage until complete fusion. Another example is this lady. She is a 60 years old lady, and she had a lumbar canal stenosis, as we can see at L3, at L4 level, and she was diabetic and insulin. She was morbidly obese, and she had this plain radiograph with, for me, it is a stable lumbar spine inflection and extension view. My first choice, if I was the first surgeon, is to do just a limited decompression for this problem. But actually, this lady had a double level fusion in another center. And as we can see, the surgeon did him an interbody fusion for L4-5 and intertransverse fusion at L3-4 with decompression, limited decompression of the both levels. And the patient went well for a couple of months, and then she started suffering again. And after 6 months, she had a significant back pain. She was a non-walker. And we can see here from this X-ray, we have a cage subsidence and loose cage. And you can look at this lower screw, it's almost touching the lower end vertebra, the lower end plate of L5 vertebra. And this may explain the severe sciatica the patient was suffering after this 6 months. And actually it has a mild elevation of inflammatory markers like ESA and CRP. And this MRI can show that there is still a problem here. There is no fusion, and there is instability of this cage, as you can see in the plain X-ray. And again, if I planned for a revision surgery, I think L5 vertebra will not hold again any screws, and I will do, after debridement, removal of the cage, removal of the fibrous tissue, removal of the infected material that may be present here. I don't think that I will kept with only an end plate or a shell at L5. So I planned to remove L5 at all completely and to do a corpectomy, posterior corpectomy of L5. And again, the problem is the fixation. How can you fix? If I did a debridement, whatever partial or complete corpectomy, can I depend only on 2 S1 screws for this revision patient, morbidly obese and with this quality of bone? And for me, I think it's not the optimal option. So I did the same principles of posterior corpectomy, debridement of all infected tissue, all fibrous tissue has been removed. And then I added iliac fixation for more stability. And I did the multiple rod constructs to protect this long cage for a long time till fusions. And now this 1 year after surgery with a patient still fine. Another example of this patient, male patient, 24 years old, he has a spondylodiscitis, multiple level spondylodiscitis, L2-3 and L5-S1, and he had a surgery with one of my colleagues, and he wasn't courage enough to put any source of cages in patient with infection, and he was depending totally on bone graft. So he did him a posterolateral fusion at upper level and interbody fusion of the lower level with bone graft only. And the patient, of course, went well for some times, and then he come back with collapsed this level, screw breakage, and reactivation of infection at the lower level of L5-S1. So we have loose screws at S1, we have destroyed end plate, infection, fibrosis, pseudoarthrosis, and actually you cannot depend on S1 or S2 or even fixation after debridement. And this is our principles was to depend on the iliac fixation and use of accessory rod and interbody debridement and the thought of mesh cage. And we thought that this multiple rod construct is stable enough to protect the patient till complete healing. And actually the success of these techniques in revision cases have encouraged us to use it in primary cases when you have a very difficult situation like that. We have a female patient, 19 years old, and she has a severe spondylodiscitis, TB spondylodiscitis, destruction of L5 vertebra, most of L4 vertebra, destruction of the upper end of the sacrum, huge amount of collection of pus collection. And again, if we planned for this surgery, actually I am expecting to remove L5, at least half of L4 and the upper part of the sacrum to do a good debridement and then reconstruct whatever with cage graft or cage graft construct. And again, my issue is how to have a stable fixation to protect this long fusion mass till healing to occur. And we can apply the same principles of using iliac screws fixation, multiple rod constructs, and debridement and the reconstruction using a mesh cage filled with bone graft. And we can see the sequestrated L4 and L5 bodies which have been removed as a one mass. So my home message, usually the golden rule that failure to plan is a plan for failure. So you have to plan to your first surgery very well to avoid a very difficult complex revision later on. And usually it's better to be safe than to be sorry. So you have to do your best in the first surgery in order not to put yourself in a situation with difficult revision. And my own policy, the minimal adequate surgery equals the maximum safety. So if my patient needs a discectomy, I will never do fusion. If my patient needs decompression only, I will not add screws. But I have to be sure that this minimal interference is adequate for the patient, is not the suboptimal. And usually in a revision surgery, you have to properly plan before surgery, and you have to adjust adequate surgical technique. And actually, you have to be sure that you have a strong, stable construct that can protect your fusion or your debridement of the pseudoarthrosis till healing. Because in revision surgery, usually you have a big defect and a big amount of bone graft that need a longer time to fuse, and this longer time should be protected by a stable instrumentation. And usually in lumbosacral revision for pseudoarthrosis, you always remember that the pelvic fixation provides a very secure fixation, and this can withstand until complete healing of it. And usually the accessory rod, put in your mind, it also can decrease the risk of rod fracture, metal failure. It may work as an external support that we used in the past, like a plastic, the plaster shell or something like that. And you can even remove this pelvic fixation, extra fixation with this accessory rod after ensuring adequate fusion and sufficient bone bridging your pseudoarthrosis site. And usually remember that the first chance is the best chance. So try to give your patient the best option in the first surgery to avoid this complex revision. And thank you very much.
Thank you very much, Dr. Bilal. The first chance is the best chance. Completely agree with you that we need to give our patients the best. That's why we are doing these webinars to change our practice. One of the comments from Dr. Khaled Asir is that he would like to comment about proper intervertebral disc preparation to achieve proper fusion is mandatory while you are doing the procedure at the index level to avoid such devastating pseudoarthrosis and complications. Dr. Bilal, there is a comment from one of our colleagues, Dr. Ihab Zayat, asking about why not to extend your fixation to the ilium, like capacious screw, instead of doing this accessory, we can call it accessory rod or your technique. Why you not use that?
Actually, it is a valid option, of course. But actually, this is the comparison between either a two-rod construct or four-rod construct. In the first cases, I used to put two rods only and connected to the iliac screws. But I have some cases with even some loosening of the proximal screws, some loosening of the nuts of the iliac screws. And actually, you are depending only on the two rods. It is the principle of four rods that you are depending on four separate rods. So if you have a problem in one rod, breakage, not loosening, screw loosening, you are still have another two or three rods to depend. So it is a valid option to have two rods connected directly to the screws, but this may work in some cases, but this I think is more secure for more complex cases.
So as you said, safe instead to be sorry. Safe instead to say I'm sorry. Okay. Bilal, what is the indication for spinopelvic fixation in your hand in primary cases? This is a question from Dr. Ihab Zayat as well.
Actually, if I have a long defect, especially after corpectomy, we have a paper in the International Orthopedic recently about the L5 posterior corpectomy of L5 for different pathology, tumors, infection, and trauma even. So if you have a corpectomy with a long cage, you are expecting healing to occur. I think to bridge the bone through the entire cage, people say that it may take 1 or 2 years. So to depend only on just one level fixation, for me, it is not that good option. So if I have a corpectomy at L5 especially, I will do it with pelvic fixation in the primary cases. Because so the rule.
So to bridge a gap, bridge huge gap anteriorly, or if you can extend the construct above L2, is this an indication as well? In long construct, you can augment by doing
if I extended the fixation above the L2, actually I may use iliac fixation, but actually it depends. If you had interbody fusion and you have a good screw holding in S1, it may be sufficient. Literature supports that it may be sufficient to have interbody fusion at L5S1 or anterior L5S1 fusion. However, if I am at risk, the patient is osteoporotic, and I feel that the S1 screws are not holding that well, and actually intraoperative, you can feel the grip of those screws. If those screws are not encouraging, so I will go directly to iliac fixation. Yes.
Okay. Last question: why not to use cross connectors? Cross links and cross connectors.
Cross links between the rods or cross connector?
Between the rods. Between the rods.
Actually, it's an option also to be used, but it takes some time. Systems that were used are generic systems. It is not original system because the original system are very expensive. And those rod-to-rod connector, in my hands, not that good connectors to be. It takes some time, long time to be adapted to these rods. But if I had an original system, yes, I put a rod-to-rod connector.
Bilal, the last case you did the corpectomy from posterior, and you bought this big long cage from posterior, yes. Or you rely on ALIF or anterior approach as well in such cases?
Only corpectomy. And actually, the issue is you don't have to look at the length of the cage rather than the width, the diameter of the cage, because you are inserting the cage with its diameter end on between the nerve root, and then you manipulate it after creating the space after debridement of the vertebral body. So it is not a difficult. Don't be shocked by the length of the cage, because you don't enter the cage with its length. You just enter it with the diameter end on. Manipulate it between the nerve root, and then you rotate it inside the disc space after crossing the nerve root.
Is there a rule for ALIF in your hand?
For myself, in my school, we don't use ALIF anymore.
All from posterior. Thank you very much, Dr. Bilal, for your challenging cases. And back to my co-moderator, Dr. Hani Sulaimani. Thank you very much.
Thank you very much, Dr. Bilal. It's amazing how you can shove in a very long rod anteriorly from posterior. I would be very interested in seeing that technique. Usually we struggle even with expandable cages, but maybe you should write this up.
We wrote it already, sir. We wrote it already, sir.
Okay.
And I invite you to read this paper. It's an interesting paper about the posterior-only approach for fifth lumbar corpectomy, and it was published indication and technical notes. It is published in the International Orthopedics Journal and describe exactly how to put a large cage and a cage like that and how to manipulate it between the nerve roots without injury and without problem.
Surely, I'll look up your paper, Dr. Bilal. Thank you very much for interesting cases. So I think we should go now to the next speaker, Dr. Amrul Habib, and he will be talking about craniocervical revision. Dr. Amrul?
Yeah, can you hear me?
Loud and clear, Dr. Amrul.
Yes, we can.
So thank you. It was nice to meet again with our brothers from Egypt. I had the opportunity to visit Luxor during their Egyptian spine meeting, and these are all Luxor photos. We had a wonderful event with our brothers over there. So it's nice to meet again, and thanks for the SSS for the initiating this movement. So I'll shift gears a little bit. This is a 9-year-old girl who is a Down syndrome patient. She had progressive decline in her ability to walk and her ability to use her hand function for over a year period. She basically did not walk for over 9 months, and she was not able to feed herself. You can see from her images that she had an atlantoaxial subluxation and an os-odontoideum, and she had a very narrow space available for the cord. And this is her MRI. So it does show a significant spinal cord compression that clearly explains all the symptoms. And we also brought back the old images. Apparently, she had an image in 2016 that also showed compression. So this has been going on for a good 2 years, maybe, before she came. And that explains two things. One, many of the Down syndrome patients, when they get worse, unless they get really worse, they are not taken very seriously, neither by family or sometimes even by the doctors, and until they are not able to walk. And there's another issue with this patient, which is access to care, because she was seen but not able to access surgical facility that could handle this kind of situation. So, so with this compression, this is, you can see the axial image at that level, very narrow and squished cord with an area of whitening within the cord. So Bilal, can you bring the poll up? What would be your recommendation? A halo vest, posterior decompression only, posterior C1-2 instrumented fusion, or occipital cervical fusion? And we can keep this, Bilal, for 15 seconds and then take it away, please, for the sake of time. So can we see the result of the poll? Yes, okay. So yeah, 50%, some people said halo vest, posterior decompression. So the issue here is pure mechanical instability. So a decompression alone would not suffice, and observation is not an option if you go by any criteria for managing atlantoaxial subluxation in Down syndrome. Once they are neurologically compromised or there is a signal change on the spinal cord, then surgery is a definite indication. Then they were left really with the two options of posterior C1-2 instrumented fusion or occipitocervical fusion, and we shall learn through the case. So the first thing I do with these cases is attraction, and surprisingly, even though she's a child and even though it's a Down syndrome, they tolerate traction fairly well. And in bed, while she was in traction, she was able to move her hands much better and lift her arms above the bed level, and that really pleased the family and pleased us as well. And I've seen this repeatedly when you do attraction. And the other thing that attraction helps, it tells you how much reduction you can achieve and whether you can actually achieve reduction intraoperatively. So it was moving and the space was opening up and neurologically she was better. So we operated in her posteriorly, and initially we aimed at doing a C1-2 fusion, and this is the patient in a prone position. And during the fusion, we did decompression as well. And after the decompression, we do an ultrasound. As mentioned by Dr. Bassem, I find ultrasound is very helpful. And you can see with the ultrasound, on your left is the medulla oblongata, or the lower part of the medulla, upper part of the cord. The lower part is the spinal cord, and where the circles are, you cannot see the spinal cord very well, and you can even see the anterior structure pushing back to the spinal cord. And we achieved, after the instrumentation, a good decompression. And this is how I confirm the decompression intraoperatively by using another ultrasound that shows very nicely decompressed spinal cord with anatomy even more clear. So that's on the spinal cord side, and we have an intraoperative O-arm. Using the O-arm, we also check our screw placement. So you really were lucky. You come out from the OR, you know where your screws are, and you know how your spinal cord looks like. And we do this under neuromonitoring. And you can see here, post-operatively at 1 week, that the spine is really aligned well at C1, C2. And we were fairly happy with this. And the patient was kept actually in a rigid collar and was discharged home. And neurologically, she was better. She started sitting, and I followed her up in the clinic. However, she came back 6 weeks later, and the family said that neurologically she's getting worse. After the improvement, she started losing some of the functions she had gained. And you can see at 6 weeks, the CT scan, how she's subluxing again. And this is on the left, and on the right, the screw of C1 is in place, but at C2, it toggled a little bit. I think she is, the screw had moved inside the bone, or there was some sort of sagittal movement leading to recurrence of the subluxation. So again, we put her in traction in the bed, and at this time, we went back and did an occipitocervical fusion. So we were lucky because she was in close follow-up, and she had good neurological improvement. She was able to use her arms again and hands for daily function, and she was able to stand with support. And I followed her up until she went back to her country. That was until 9 months after the procedure. So this raised questions. I looked at the Down syndrome cases that I had operated on them, and the first two cases I helped other surgeon to fuse the occiput after a wire failure. So initially I thought maybe it's a wire issue. It's a wiring issue. And then two patients with rigid instrumentation, and the two patients also recurred. And I was lucky that I had 3 other patients that did not recur. So I searched the literature and started thinking, what is the issue? Is it a Down syndrome issue? Is that late or chronic kind of presentation? Was my construct not very good? Whether I should have put the patient in a halo after surgery? And also instructions to the family. It turns out that when the patient is really neurologically bad and the mother is the caring person and she wants to sit her daughter up, she would lift her head from putting the hand and pulling her up. And that was poor instruction from my side, not to tell her not to do that. In the literature, this is a recent paper published in 2018. 7 centers in North America included 131 patients, and it included all kids, all pediatrics with atlantoaxial fusion failure, and Down syndrome was the single most important factor for fusion failure, with the odds ratio of 14.6. And the authors talked about the possible problems with Down syndrome, like weak bone, abnormal healing due to collagen abnormalities, immunodeficiency. I also would add psychosocial factors and family factors that I just mentioned. Another paper that looked at outcome posterior arthrodesis, atlantoaxial subluxation, and look at the list of complications. These are all many studies, well-done studies published in good journals. Bone complications up to 40%, neurological deficits in a quarter, reoperation rate more than 30%, so almost 1/3. Given the fact that maybe some of these papers were done with a non-very rigid fixation, there are individual variations to Down syndrome, not every Down like the other Down. However, collectively, the risk of recurrence in these patients and reoperation or even mortality is 4%. So that's my message from this case. Usually C1, C2 fusions they have good fusion rate. I had none of the trauma patients I did had recurrence. The ones that have recurrence tend to be syndromic. I think Down syndrome is the least of the syndromic ones causing troubles. At least when you revise them, they do well. I try to do C1, C2 and spare the occiput whenever I can. I leave the occiput if there is a true indication like a C0, C1 problem, or in a revision case like this. And you can see here, patients presenting with neurologic deficit, like this patient, would have a 4-fold neurologic complications and 5-fold risk of reoperation. So I think I'm done. I'm happy to go back to any one of the slides I presented. Sorry, I went over. I just wanted to not take a long time.
Maybe keep the slides from Aloxo.
Okay.
Okay.
So
can I have one comment, please?
Go ahead, Dr. Bilal.
Yes, actually, thank you, Dr. Amro, for this nice case. I have just one comment because I had already a patient 9 years old exactly like that, and he wasn't Down syndrome. He was C1, C2 instability. And actually, my recommendation in pediatric patients, never ever depend only on the screw fixation at C1, C2, because the screw is holding very well during the surgery. But those young patients, the bone is plastic and elastic, and this is what is written, and they can expand after some time, and you have a screw loosening. So we have one tip, which is an easy, cheap, and usually protect our fixation, and this is what's called the first chance, also the best chance to avoid subcervical fusion, which is Minerva cast. So routinely after this patient, I'm doing Minerva cast for all patients pediatric population with C1, C2 fixation for 2 months at least. And actually, yes, it is a little bit cumbersome for the family for 2 months, but I have a very good result after adding Minerva cast for a C1, C2 fixation in pediatric population.
I would totally agree with you. We have non-invasive halo now, so if the patient, I could see that will tolerate a non-invasive halo, I would put a non-invasive halo, and in others I put Minerva.
I do the Minerva cast under anesthesia in the first surgery. I don't wait for any signs of instability. I do it immediately under anesthesia after my fixation. And actually, even with halo, the halo it is a little bit, the patient can move a little bit, but Minerva cast, all this gold, it is a very tightly fitting, and the patient cannot even micro motion of his head, and this protect your fixation. And it is cheap also. It costs nothing.
Yeah, excellent. So external stabilization, the more rigid you go, the better after these surgeries.
Especially in pediatric patients.
Yep.
So we have a few questions here. So for the sake of time, maybe we should go through it quickly. So one question from David: Did you manipulate or fuse the C1, C2 joints?
I tried to get into the joint whenever possible. During the surgery, you try to mobilize the C2 nerve root and try to get into the joint. The capsule is very tough, so you can use a Colorado needle or a sharp micro dissector to get into the joint and curate the joint, which is a good site for fusion. So if that's, or does he mean manipulation by trying to manipulate C1, C2 in order to achieve the reduction?
I'm not sure that was the question, but I think it was, as you mentioned, maybe just to manipulate and fuse.
So for fusion, that's what I do. Sometimes if the C2 doesn't come back, you try to understand the mechanics of the C2 and whether you can actually push it more anteriorly using your construct. And I have done that, and it does work very well.
So the next question is, how about transoral? We have a couple of questions about transoral approach before posterior fixation. And
so,
do you use or do you order for a post-operative MRI or not?
Yes, so transoral before posterior fusion for this case is a contraindication because the issue here is a dynamic instability, and the last thing you want is to further destabilize. I mean, after you do posterior fusion and you are still left with a rigid anterior construct that does not want to come back, you might consider a transoral, but it would be a heck of a deal for Down syndrome because they have big tongues. And I mean, nowadays there's endoscopic approaches, but the rate of transoral has declined significantly after posterior, after understanding the biomechanics of the area and posterior stabilization.
Actually, you need transoral much more if you have basilar invagination, and the odontoid is the compressing agent. In this patient, the odontoid is not compressing, the arch is the compressing agent. So you don't have to remove it at all.
Yeah,
so
I would agree with you.
How about occipital decompression and intraoperative traction?
Yes, so I did preoperative traction for this case. Preoperative traction, I find it works very well. I have done intraoperative traction for a Down syndrome that did not think that is cooperative, nor the family was cooperative. And it did help actually very well. You have to be very careful with intraoperative traction. You increase the weight very slowly under X-ray guidance. You have to, and neuromonitoring very carefully. You can lose the signals if you do intraoperative traction without monitoring. So that can be dangerous when the patient is not awake.
Foramen magnum decompression?
Yeah, so it depends on the compressing element. This foramen magnum decompression is usually reserved for an associated Chiari.
Yeah, yes.
There is no Chiari here. And you could see on ultrasound, we don't have to guess. The ultrasound shows you very well that you have no compressing element. Behind the cord, it's all CSF. So it's full. The space is nice. One thing, caveat for Down syndrome cases and syndromic cases, please do a CT angio and study the artery very well, because the artery can take an artery, or the pica can become extradural while you think it's muscular, but it's not a muscular artery. So I would do a CT angio on occipital-cervical fusions or C1, C2, particularly syndromic cases. I wouldn't just rely on flow voids MRI.
Well said, Dr. Amro. I think we're just a little bit late over schedule, so I think we should proceed for Dr. Muhammad Khattab. Last but not least, he'll be talking about subsidence in adjacent segment disease.
Thank you very much, dear Dr. Hani. Thank you for Saudi Spine Society for inviting the Egyptian Spine Association for this conjoint meeting. It was very fruitful cases, nice discussions. I enjoyed it very much. My talk today about cage subsidence. And I'd like all the attendees to stretch their legs and stretch their backs. It was long cases for discussion. While doing this, we will start by doing polls. Can dear Mr. Bilal launch the first poll to engage our attendees? So, okay, these are two questions I'd like to hear from you regarding the lumbar cage subsidence. Can it lead to breakage of the screws? Can it lead to foraminal stenosis, segmental kyphosis, or all of the above? And second question regarding it may be related to patient factors, implant design, or bad surgical technique. So can you submit your answers, and would like to see the results of the poll right now, Mr. Bilal? Excellent. So you achieved more than what I was expecting. So we can conclude this presentation. You achieved the intended learning outcomes. Thank you. So cage subsidence, my learning objectives from this talk is to identify different types of cage subsidence and to differentiate between adjacent segment pathology and disease, which is a symptomatic one, and to give some strategy regarding managing these cases. I will start my presentation with this female patient, 55 years old, presented to me 6 years after doing this double level fusion for her back pain and spondylolysis, and she had complaint only for 10 days, very mild low back pain, and this was a routine follow-up x-rays after 6 years. You can see here breakage in the screws at S1, and we can see here cage subsidence at the L45 and 5 S1. Another case presented to me, 50 years old female, after 1.5 years from the surgery for doing this 3-level interbody fusion, and we can see here some loosening, some halo around the screws at L5, and we can see different types of cage subsidence at 3, 4, 4, 5, and 5 S1 levels. And the complaint for this patient was only in with cramps and radiculopathy at L4 distribution. The third patient I'd like to discuss with you is this male patient, which is presented to me 3 months post-operatively with failure of the construct and breakage of the upper end plate, and we can see cage subsidence here. This is a malpositioned screw from the beginning because it is 3 months, that's too early. Is it a cage subsidence that can create abnormal stresses over the construct, lead to breakage of the end plate, or the patient is really osteoporotic and this is a devastating complications from the osteoporosis? From the history, if the patient has trauma or fall, which was actually denied by the patient, we cannot accept that implant failure is only due to biomechanical factors, but you should consider infection in any construct failure, especially if it is a recent construct failure. And of course, the spinopelvic parameters and the sagittal malalignment should be considered in your cases. I'd like to highlight something: radiological adjacent segment pathology. That is the anticipation of disc degeneration or disc prolapse or even spondylolisthesis or even fracture, infection, or facetal arthropathy or arthritis. And this can be anticipated in 27% of the patient after doing lumbar fusion. And it is only radiological finding. But when these patients start complaints and they have significant back pain or symptoms and signs related to this adjacent segment pathology, hence we call it adjacent segment disease or clinical adjacent segment pathology. And it has a range of from 2 to 9% in the literature. And of course, it can cause physical and financial burden to the health community. Some colleagues advocate that there are some risks to develop adjacent segment pathology, like the use of antidepressant, the presence of degenerative scoliosis, or the loss of spinopelvic parameters. If you have fusion length and you have long construct, that can add a lot of stresses to the adjacent level, creating adjacent segment pathology, having decompression nearby, or the presence of osteoporosis. Let us focus on cage subsidence as a theme and the title for this presentation. Why we apply cage? We apply cage in order to maintain the intervertebral disc space. We are indirectly restore and maintain the intervertebral foraminal height and decompressing the nerve root inside the foramen. We support the vertebral body and unload the pedicular screws, and we unload the posterior facets, and we need to restore the sagittal alignment. And if we start to study these cases, these 3 cases, we can find that we have some drawbacks from didn't achieve the goal of our surgery. Cage subsidence is the subsidence or thinking of cage or spacer with greater modulus of elasticity inside the vertebral body with lower modulus of elasticity. And the cage subsidence has positive effect. Yes, it can fasten the fusion, but of course it have negative effect because it changes the spinal geometry. So it can affect the integrity of your construct and can lead to further symptoms in your patients. And the problem is maybe a technical problem, maybe a bone quality problem, and maybe implant-related problems. Let us discuss some tips and tricks, because in order to get out of trouble, that is really bad, but it is important to stay out of trouble. So I do believe while preparing the disc space, it is really mandatory to avoid disastrous complication which can be anticipated later, like pseudoarthrosis, construct failure, cage subsidence, and so on. So while preparing the disc, please remove only the cartilaginous end plate. Avoid remove big part of the bony end, any part of the bony end plate that can cause subsidence. While doing the interbody preparation, while using the shavers, please don't put the rod and don't fix your segment. Allow the segment to become mobile while you are twisting and turning the shaver on, in order to not to breach or break the end plate. Not over distract this segment. Over distraction can create instability. Over distraction can be followed by recoil and cause subsidence later on. So to overcome the bad surgical technique, you need to properly prepare your end plate. Avoid the segment by screws and rods before putting the cage. You need to leave it, and you can rely on intervertebral or interlaminar spreader that can help you to put the reamer, then release the distraction and start to do the reaming and the shaving. In order to avoid neurological signs and symptoms or any devastating neurological complications from cage subsidence, do generous foraminotomy while you are doing fusion. Some colleagues may advocate remove part from the posterior end plate to widen the introitus of the disc space while doing the cage, but I don't rely on this. I rely on putting the interspinous spacer or the intervertebral distractor, that helped me a lot to put the proper size cage. So to repeat again, because it is important, kindly remove only the cartilaginous end plate, preserve the bony end plate. Presence of bone stock is mandatory for your cases, so put cage filled with bone and put bone around the cage as well. Gentle compression over the cage after doing the procedure, and do proper foraminotomy to avoid neural compromise, and support, of course, your construct by proper screw diameter. Regarding the bone quality, osteomalacia, osteoporosis, or associated medical conditions like renal failure, bone softening disorders, presence of infections, or these are risk factors to develop cage subsidence. So prepare your bone well, and you can give the patient some anabolics. You can improve the osteoporosis as well, and of course avoid overcompression. And this is a merit for applying a cross-border cage, bigger cage from anterior through anterior approaches like ALIF or OLIF or anterior to psoas approaches, which is very helpful in osteoporotic cases. Regarding the type of implant, of course, don't put small implant with a small footprint. Cross-border cages, bigger cages are much better. PEEK has modulus of elasticity near or similar to the bone, so it can better for substance, unlike the titanium. Anatomical, of course, cages better than rectangular cages. The cage edge and the corner configuration is very important. Sharp edges can create some fractures in the end plate. This is one of my cases. Look, this is a tantalum cage. It was really not an easy job to apply it, and you use smaller cage in comparison with the other cages. I prefer these bullet-like cages, for example, with tapered end. It will be very helpful while applying these cages through the introitus of the disc space. It helps to slip anteriorly, and then you, of course, as I told you before, you can rely on interspinous distractor, put the tip of the cage, then continue by hammering it after releasing the distraction. And of course, be very careful while you are using telescoping cage or metallic cages. So I do believe big cages is giving good results in my hand. Round corner cages is okay. Metal cages, although they are more better in achieving diffusion, but be careful with applying them technically. So this is a meta-analysis regarding the case subsidence. It's range about 7.5%. It commonly occurs in the first 3 months of life, common with greater cage height, common in females, and large subsidence more than 3 millimeter can be anticipated in the first months. And it is, of course, more common in titanium when you compare it with big cages. And of course, the use of screws can decrease the incidence of subsidence. The scientists classify the subsidence according to the grade of thinking inside the vertebral body into 4 types. Grade 0, from 0 to 24, from 25 to 49 is grade 1, from 50 to 74 is grade 2, and grade 3 more than 75%. And the risk factor, as we stated during this presentation: osteoporosis, multi-level fusion, older age, female sex, obesity, case subsidence. And they stated that 4, 5, and 5S1 has higher levels of cage subsidence due to the biomechanics at these levels. And I'd like to come back to my cases. This patient was actually came for a routine follow-up, and she has no complaint, no significant complaint, although she has radiological finding of cage subsidence and failure, but there is no motion at the flexion extension, 6 years post-operative, and very mild back pain for 10 days, which is actually nothing. So no complaint, no treatment, but we must respect the patient and respect the x-rays as well. So what I learned from this case regarding the screw design, the conical designs of the screws are really break much in comparison with the cylindrical screws. This is my experience. Also, the type of peak. We have 2 types of peak: oxy peak, which is considered as a plastic, and peak optima. Peak optima is okay and is fine, and most of these cases come sterilized in a package. If the patients underwent surgery and you ask the company to bring to you peak, consider the sterilized one, not use these cages which you re-sterilize if time by time, because it may have changes in the mechanics and it can lead to subsidence and it can lead to some complications like these fractures. And although we have subsidence, we have good fusion, we have no complaint, so no intervention. This patient, 3-level fusion, the last one not fused, was loosening around the screws here. Types of case subsidence. Here we can have type 3, 100% case subsidence. Here we can, it is a type 2, more than 50% subsidence. Here more than 25, so it is type 1 case subsidence. But this case we can revise here and do foraminotomy and revise by putting and applying bigger screws. Of course, screw designs, you can consider these screw designs while you are operating your patient, and this is after revising the case with satisfactory results and achieving of fusion in the CT. The third case was complete loss of the construct after 3 months and case subsidence and the breakage of the constructs. I decided to revise the patient by applying bigger screws in another trajectories. Due to the osteoporosis, there were no infection. I decided to augment the proximal construct by this cementation. It was not a fenestrated screw. I applied the cement, then I put the screws, and I only revised the screws, and the patient went well and have satisfactory results. And he followed up with me for 4 years after this revision, and he is okay. So my take-home message that look for the details. It is important. And I think my take-home message is a conclusion for our presentations. All of us, look for the details. Look for your patient. Look for the complaint. Look for the examination. Look for the diagnosis. Look for the armamentarium you have. Look for the implant. Look for the investigation. Each details. Do checklist for yourself. Checklist for your patient. Properly manage your patient and probably plan your patient, because failing to plan is planning to fail. This is the end of my talk, and I'd like to thank all my brothers and colleagues from Saudi Arabia and from Egypt for this fruitful meeting, and looking forward for further cooperation as usual. And I'd like to thank my co-moderator, Dr. Hani Sulaimani, and Mr. Bilal, our host. And thanks for the attendee. It was really fruitful meeting as I am expecting. Thank you, Dr. Hani.
Thank you very much, Dr. Muhammad. Really interesting presentation. I mean, it's very valuable because most spine surgeons do these procedures on a daily and weekly basis. And as you mentioned, there are different variables regarding the patient himself, the implants, the surgical technique. I mean, all of these variables may affect our outcome. So we should, I mean, stick to the principles, especially when it comes to biomechanics. There is one question here from Ahmed Al-Rifai asking about standalone cages. Do you consider doing standalone cages, minimum invasive microdiscectomy with adpedicular screw fixation? Do you think that's a good idea, Dr. Muhammad?
Regarding standalone cages, I am not a fan for this technique. There is no rule for standalone cages in a spine surgery. That's what I believe. Except if you will do, for example, ALIF, and it will not be. Sorry, Bilal?
In lumbar spine surgery.
Lumbar, yes, yes. I am focusing on lumbar spine surgery. In lumbar spine surgery, no rule for standalone cages, except if it is anchorage cages. You can put huge, big cross-border cages with screws, anchored cages with screws anteriorly. And I do believe augment your construct by percutaneous screws will cost nothing. If you will asking about cost effectiveness, it will cost nothing. 4 screws nowadays in many countries you have locally manufactured screws. It costs really nothing. So no rule for standalone cages in lumbar spine, because it you know, at a stage of flexion extension, there is a zone, there is no stability around these stand-alone cages.
Great, Dr. Mohammed. My next question will be from me personally. What do you think about expandable lordotic cages, especially those large disk spaces like L5S1, where you find a very narrow isthmus or entrance for the cage and a very wide anterior interbody space? So would you consider an expandable cage for that, or you use any other techniques?
To be honest, we don't have expandable cages, telescoping cages in my country, but from your point of view and as generally speaking, of course, it has a rule. As you just mentioned, in narrow introitus, you can use it and you can expand it. It is a fancy, nice tools, and it can add a lot for you. I think it is very nice technology.
Do we have any other questions from the panel?
Just I have one comment about the screw breakage. The screw breakage, we have many cases of completely fused vertebra with screw breakage. The screw breakage can occur at sometimes earlier than the presentation of the patient. And actually in interbody fusion, especially, when you have a screw breakage, you may have more collapse, and this can cause more compression of the interbody graft or cage. So don't depend only on screw breakage as a sign of pseudoarthrosis or something like that. Because I have several patients with a broken screw, and after CT scan, the patient is 100% fused, and exploration for metal removal or possible revision, you find the patient is completely fused. So it is written that the screw breakage can occur at early stage, and this after that the patient can get fused.
So as Dr. Mohammed, he mentioned earlier, maybe subsidence sometimes will aid in the earlier fusion. So
yes.
Maybe there is
it is a positive effect of substance.
Yes.
It can fasten the fusion. Yeah.
Great,
yes.
Great. I think we had a magnificent conference. I would say it's a conference now. It's not just a webinar, mashallah. And we have an elite, really good number of faculty, very interesting cases. I think we learned a lot today. Personally, I have. And I really thank you all. I thank all the speakers for giving their time and effort. And I thank all the participants. MashaAllah, we have been over 400 for the last, for the whole webinar. And that gives you an idea about the passion that all our colleagues have in grasping the knowledge. So I thank you all, and Jazakumullah khairan. And I'll hope to see all of you soon, inshallah, in a very near future, بإذن
إن شاء الله الرحمن جزانا وإياكم.
شكرا جزيلا.
السلام عليكم ورحمة الله.
خير.
شكرا جزيلا.
الله.